Hello, welcome to the session on ECG interpretation. This session might be a bit longer, so depending on time, it might be broken up into one or two parts, but we'll see how we go. So we'll start off with ECG, and I know it can seem intimidating to look at it for the first time, and I certainly did, but it's all about practicing and applying it in different ECGs, and over time, you tend to get better and better at it. So we'll start off with the electrophysiology of the heart. So the heart pumps according to an electrical system, and this governs how the heart pumps blood around the body. Now, in ECG is a device we can use to track and monitor the electrical activity in the heart. And this can give us an indication whether there is any issues or any abnormalities in the electrical activity of the heart. So start off with how this electrical system starts. We first have something called the sinoatrial node, or the SA node. The SA node will then send off signals, which will then lead to atrial contractions. It will lead to the contraction of the right and left, and the signals will then meet at the AV node. Here at the AV node, it will pause for a bit of time, allowing the atria to fully contract before then traveling down the bundle of His. It breaks up into two branches. So you got your bundle branches. You got your left bundle branch and your right bundle branch. Your left bundle branch is broken up into your left anterior hemifascicle, which kind of wraps over the front, and the left posterior hemifascicle, which kind of goes lower down and wraps around the back too. Then you've got your right bundle branch, and there's only one of them. So our heart usually starts off with our sinoatrial node and travels to our AV node, where it pauses, allowing our atria to contract, and then down this pathway. While it goes down this pathway, it will then turn into smaller fibers called Purkinje fibers, which then innervate our whole myocardium, which is the muscle of the heart to pump blood throughout our body. So as we can see, it's all started with our sinoatrial node. So our sinoatrial node has a natural pacemaker of the heart. It has a heart rate about 60 to 80. But our heart rate or our pacemaker doesn't have to start from the sinoatrial node. In fact, it can start from the AV node. It can even start from the bundle of His or even the ventricles itself. The lower down it goes, the slower the heart rate tends to become. So if it starts at the AV joint, it'll be about 40 to 60. But if the pacemaker starts around the hemifascicles, there is 20 to 40. These are not normal. These are abnormal situations when the natural pacemaker shifts location. But generally, we want it to start at the SA node. So the SA node and the AV node only has one stimulus. So it requires recharging. So when there is different stages of a single heartbeat, we've talked about it, the atrial depolarizing, then it travels down and leads to ventricular depolarizing. Then we also need repolarizing. Once it depolarizes, it needs to recharge and it becomes repolarized. All right, let's move on to the next slide. So our ECG monitors are used to detect different wavelengths of but depending on the direction of the wave, it registers a positive or negative value. So as we can see, when a wave is heading towards a lead or a monitor, it registers a positive signal. Because it's moving away from this monitor, it has a negative value. When it's traveling perpendicular to the wave, it has a biphasic. So it goes up and down, so a biphasic wave. And it makes sense because as it comes on initially, it starts with the negative and then it becomes neutral. And as it moves away, it becomes a negative value. And as you can see, when it tends to be closer to this lead, it tends to be a more prominent negative. And when it comes to this lead, it tends to be a little bit more positive. So remember, when it heads towards directions of positive, away is negative. So an ECG or an electrocardiogram allows us to monitor the electrical activity of the heart. And we need to look at a heart at a number of various angles. Just looking at one direction doesn't really give us a clear indication of what the heart's doing. So we've got different types of leads. We've got limb leads and we've got precordial leads. So here's our precordial leads. We've got V1 that sits around here at our right sternal ledge, and you got your left sternal ledge, and so on as it wraps around the chest. And as you can see, it's looking at the heart at various angles. It doesn't stop there. You can also actually extend your ECG into placing more leads posteriorly or on the right-hand side as well. But in the most standard case, we usually see 6 precordial leads. We can also use the limb leads to calculate different types of directions to look at. So lead 1 looks at it from this way. Lead 2 looks at it downwards. Lead 3 is looking at it in this angle. AVF is looking downwards. AVL is looking towards the left-hand side, and AVR is moving to the right-hand side. An easy way to remember is AVF. F is for feet, it's going downwards. L is for left-hand side, and R is for right-hand side. 2 is our downwards this way, and 1 is our horizontal. 2 is the most classic lead of the heart, because if we go backwards, we can see it goes from the right to our AV node and passes down a bundle of His. And you can see that angle and that vector that it's conveying at is very similar to the lead 2 placement. So when we are looking at an ECG, we can correlate that to what the heart is doing. So our P wave is representing our atrial depolarization. Then our pause here refers to the AV node pausing the signal for a little bit, allowing that atrius to contract and send the blood into our ventricles. Then our QRS complex refers to the signal resulting in ventricular depolarization. And then we've got the T wave, and our T wave represents ventricular repolarization. So ventricular depolarization for the QRS, ventricular repolarization for the T wave. So a P wave represents atrial depolarization. So where does atrial repolarization occur? In fact, the atrial repolarization actually occurs a little bit after the atrial depolarization. However, it's hidden by the very dominant QRS complex, so it's probably submerged within this wave. So first thing of an ECG, we're going to go through steps on how to interpret an ECG. So it's very important we go through a systematic way in interpreting the ECG. And we always start with the rate. So what is the rate of our rhythm? So there's a number of ways to look at rate. One common way that I always use is if it's a 10-second strip, a standard strip, you can count the number of QRSs. So there's 9 QRSs, 1, 2, 3, 4, 5, 6, 7, 8, 9, and you multiply it by 6, which will lead us to 54 beats per minute in 1 minute, as it's a 10-second strip. If you don't have a 10-second strip, then we rely on using the small or large squares. So we can count the number of small squares, and 1,500 divided by the number of small squares, which can also give us 56, or 300, which is a number of large squares. So 300 divided by the number of large squares. So in this case, it'll be 1, 2, 3, 4, 5, and a little bit. So 5.4 as they've discussed over here. And that has led us to 56 as well. I prefer this way as calculating it because not all the rhythm are going to be regular in pattern. So if there is an irregular rhythm, then the distance between these two might not be the same as distance between these two. So therefore you might get a more inaccurate representation of the rate, by calculating it in these two ways. But in certain circumstances, you have to be reliant on this method to calculate the rate. So that leads us to rhythm. So rate and now rhythm. There are three types of rhythms it could be. It could be a regular rhythm, as we can see here, it's a sinus rhythm, and it's quite regular at the QRS complexes are occurring at a regular rhythm. You can have a regularly irregular rhythm, which means that it's irregular, but it repeats itself after a certain number of times. So this is a classic example, number D, where you've got an AV block. So as you can see, the distance between this one and the distance between this one, and then this, there is definitely an irregular pattern going on here. However, can you see that these three waves are similar to these three waves, and you're going to expect that to be the same. So it's going to be repeating itself. So that's called a regularly irregular rhythm. It's going to be regular because it's going to repeat itself. Our last one is irregularly irregular. And our classic example is atrial fibrillation. In fact, whenever we have an irregularly irregular rhythm, we should be thinking whether this is an atrial fibrillation. And in most cases, it is. So this is when the QRS complex, so this is an irregular rhythm because there's different spaces between the QRS complexes, and there's no particular pattern like D. It happens in an irregular fashion. Next thing we'll talk about is axis. So in terms of axis, we need to look at the different angles. So we have our limb leads charted as here. As we can see, AVF is feet to the bottom, AVR to the right, AVL to the left, and it gives us a different in terms of the axis. So the axis is telling us about when you have all the directions of the electrical activity of the heart added up, there seems to be a vector. And we talked about this. Most of the times it seems to be around the second lead, SA node to the AV node to the ventricles depolarizing. It tends to have this kind of angle. However, due to some sort of pathology, our heart can then shift our electrical axis. Therefore, because of maybe an area is blocked, so the electrical current would favor one side more, leading to a general vector being in a different angle. Therefore, the axis will be shifted. So when we have a pathology example with a block, all the electrical activity will be diverted to another direction and have a shift in the overall vector. Let's have a look at an example. So I always tend to use, there's a number of different ways to calculate axis, but my favorite way is to look at number one and AVF. As you can see, number one is my x-axis and AVF is my y-axis, but it's a little bit different in the sense. So here you can see that number one, it seems to be more negative. The QRSs is more in the negative direction. Therefore, I know that it's going to be in this side of the line because this is my lead one and it's negative. So it's going to be floating around here. Now I'm going to look at my AVF. So AVF seems to be quite positive. So I know that AVF is going to be going in the positive direction. Given both of these together, I know that my overall vector is going to lie over here. And this seems to indicate as a right axis deviation. All right, now that we've identified right axis deviation, what does this mean? Well, let's go through the different causes of right axis deviation. So there could be a right ventricular hypertrophy. There could be a right ventricular strain. And this is usually due to pulmonary pathology. So when there is stress in the lungs, especially with pulmonary hypertension or COPD, with pulmonary embolism or COPD, then our right ventricle is going to work harder, and therefore you're going to have to see a right axis deviation. Other causes might include an anterior lateral STEMI, a right bundle branch block, a left posterior fascicular block, certain sorts of arrhythmias. An interesting one is dextrocardia, in which most or your organs are on the opposite side. So the heart will be present in the right-hand side of the chest rather than the left. Interestingly, tall, thin body shapes also exhibit a right axis deviation, and it can actually be a normal finding in children and adolescents as well. Then there is left axis deviation, and this is present in the right axis deviation was due to right ventricular hypertrophy, which makes sense as a lot of the electrical signals are now being more stronger on the right-hand side due to hypertrophied muscle, similar with the strain. And here we can use that same logic to apply it to left ventricular hypertrophy. Similarly, if you have a left bundle branch block, you're going to have a left axis deviation. Inferior MI is another cause, left anterior fascicular blocks, ventricular pacing. Interestingly, short squat body shapes are more associated with left axis deviation, and metabolic derangements like hyperkalemia. All right, so now that we've identified our axis and where it's lying, it's now time to look at the P wave. So what is the P wave? Remember, it's the atrial depolarization. And let's go backwards. So it starts off with a P wave going to our right atrium and then our left atrium, because our right atrium is much closer to the sinoatrial node. So we know that it's going to be depolarized first, right to left. So when the valves are open between the atria and the ventricle, around 70% of the blood from the atria is going to be fall due to gravity. The 30% is going to be assisted with the atrial contraction. So it's quite an important adjunct to the blood pumped by the heart. So important sizes, the P wave should be around less than 3 small squares. And its amplitude, how tall it is, should be less than 2.5 milliliters in the limb leads and less than 1.5 millimeters in the precordial leads. These measurements, you don't really need to memorize them, but kind of recognize when you see a P wave that does seem abnormally large, that you can identify it easily. So here you can see the P wave is not really one wave. It's composed of two smaller waves, which are very similar in their timing. So the first one's going to be our right atrium. Second one's going to be our left atrium. And they seem to appear as one wave together. So there can be abnormalities in the P waves. So let's talk about that. P mitrale, P pulmonale. So P mitrale is left atrial enlargement. So as you can see in the first picture, the dotted line seems to represent the normal P wave. And you can see there's a much taller peak in that second wave. That's called P mitrale, and it's due to left atrial enlargement. What causes left atrial enlargement? It could be mitral stenosis, mitral valve regurg, hypertension, or hypertrophic cardiomyopathy. And it's a genetic disorder in some cases, and it can lead to hypertrophied ventricles. And it's a condition as well that is associated with sudden cardiac death as well. As you can see, the P mitrale is associated mainly with a lot of mitral valve issues, and that's why it's called P mitrale. P pulmonale, as you can see, so it's going to be associated with a larger first wave, and then a second wave is usually included into the wave. So it's going to be our first wave that's causing the issue. This is due to right atrial enlargement, because remember, our right atrium contracts before the left. Causes of right atrial enlargement, there's pulmonary valve stenosis or increased pulmonary artery pressure. And due to pulmonary issues, it's usually called P pulmonale. Other abnormalities that you can note in P waves that we'll go on into more detail in future sessions, the P waves may be inverted or even have variable P wave morphologies as well. So what is the PR interval? So we've talked about the axis, now we've talked about the P waves, next the PR interval. This is representing the delay at the AV node that allows the atria to pump enough blood into the ventricles, because remember, it's responsible for 30% of that extra volume. So normally this should be about 3 to 5 small squares. And if it's longer, we should consider a first degree AV block. And this may be by itself or can even be with other blocks as well. If there is a short PR interval, we need to consider whether there is a pre-excitation syndrome or an AV nodal issue as well. So what does that mean? So because a P wave then has a delay and then a QRS appears, if there's a short PR interval, maybe there is some sort of accessory pathway. So here we can see this is a bundle of Kent, and it allows an accessory pathway. So our P waves contracts our atria, and it doesn't have to wait at that AV node anymore. It takes a little shortcut down this accessory pathway and pre-excites, so allows an excitation of the ventricles before it normally would. So now we've got a P wave and quickly a QRS without that waiting. That causes that short PR interval. This condition is known as Wolff-Parkinson-White syndrome, and we'll go into more detail in future sessions. Now it's our PR segment. So we've talked about P waves. We talked about our PR interval. Now let's talk about the segment. Usually it's flat to the line. It's usually down to that blue line. However, there can be some abnormalities. So when it says isoelectric line, it talks about the baseline that it's meant to sit at. However, there can be abnormalities in the PR segment. And in particular, it can be elevated or depressed in atrial ischemia, or in pericarditis, it can be also depressed as well. So here we can see some depression, and this ECG is taken from a patient with pericarditis. Here we can see in this with the P wave, and we've got an elevation, and we've also got, here we can see some depression of the PR segment as well. And this is with ischemic changes in the heart. All right, now we've moved on to the QRS complex. So in terms of the QRS complex, we will talk about the Q wave and the R wave and the S wave, and separately. All right, we'll stop it there for the first half and we'll continue on from the second half.